I'm sure that we will have some more faces joining us, but I also know that Dr. Tootoosis has lots to share with us today. So we will get started. Welcome and thanks for joining us. I'm really looking forward to today's conversation. I want to start with a few housekeeping items, as always, before offering a land acknowledgement. First, I'm going to ask that everybody keeps their videos and microphones off during the presentation. That will allow you all to use the hide non-video participants option, and that'll help to highlight the speaker. I'll set aside about 10 minutes at the end of our session for questions, so make sure that you post any questions that you might have in the chat. Hi, Johanna. My name is Natalia Mason. I'm the Community Engagement Specialist in the Division of Social Accountability. I'm joining you today from the College of Medicine's main campus in Saskatoon, which is on Treaty 6 territory in the homeland of the Métis Nation. Like most of you, my life has been enriched and sustained by the care and stewardship of these lands by Indigenous people. Even on days like today where it's blustery outside, I'm extremely grateful to call this territory home. The DSA undertakes its work from an intersectional lens, which considers the relationship between power and varying forms of oppression. In a Canadian context, it's really critical that we're able to reflect on the historical and ongoing impacts of colonization on Indigenous people and traditions in our communities. I understand that the opportunities that have been afforded to myself and my family have not always benefited Indigenous people in Saskatchewan in the same way, and in some instances have perpetuated harm. It's a colonial history that brought me to this conversation today, but it's with a spirit of reconciliation and a commitment to good relationships that I center my work at this university. For those of you who are unfamiliar, the Division of Social Accountability is a division of the College of Medicine dedicated to health equity, anti-racist education, community-based research, advocacy, authentic partnerships, and the health needs of underserved and marginalized communities. We engage with and learn from our communities to support relevant, meaningful, and impactful health professional education, research, service, and advocacy. We offer our health equity webinar series to support student, faculty, and staff learning in the College of Medicine, touching on some of the priority health needs of those in our community. These webinars are always open invite, so we encourage you to spread the word to friends and colleagues to join us. This month, I am really excited to be welcoming Dr. Janet Tootoosis, Vice Dean of Indigenous Health, to present. Dr. Tootoosis is a Cree woman from Poundmaker Cree Nation and has been a practicing family physician since 2001 in North Battleford, Saskatchewan. She's been a clinical associate professor since 2008 and is owner-operator of the North Battleford Medical Clinic. Dr. Tootoosis possesses an extensive history of active participation in healthcare delivery and medical education initiatives in the region and province. And with that, I will turn it over to you, Janet.
Thank you, Natalia, and thank you everyone for showing up on an afternoon and your lunch break. So really appreciate you're here, hoping that the discussion today is valuable to you. And I hope to leave enough time so that questions can be answered and we can have a bit of discussion for those on the call. And if you are comfortable, I'd really appreciate if you could just put your background in the chat with regards to whatever you feel comfortable sharing about yourself, whether you come from the health field, whether you're a community advocate, or what role you're presently in, so that I can ensure that I'm not making assumptions about the audience and that I can tailor things as we go to make this worthwhile. So I'm just going to share screen here, and Natalia can tell me if it's working.
You're golden.
Okay, so we're good to go. So now it's not going to want to move for me. Oh, there we go. I'm just going to see if there's a bit of a lag and it's going to keep going. Nope. Okay, so during the next 20 minutes, I plan to share a working definition of Indigenous health. I am not an authority. I have Harvey Thunderchild in attendance today. He's the cultural coordinator for the Office of Vice Dean Indigenous Health. And he will check me if I am out of line and help out if need be. So I will speak briefly on racism and Indigenous health impacts, then spend a bit of time discussing current work underway in the College of Medicine to create a Department of Indigenous Health and Wellness that is powered by community partnership. And I hope to focus on community partnership and what that might look like. And I hope to have an open dialogue on ideas and current activities and initiatives already underway to share in the successes. So like I said, I'm hoping to be done within 20 minutes. And if there are no questions or discussions, then we get a little bit of our time back. So, oh, I'm already off sequence here. So this is my background slide, and Natalia covered a lot of it. I have extended family across North America and probably beyond for those who've moved away. I feel I'm connected to my home, land, kin, and creatures, except spiders and snakes for obvious reasons. But no, we can't leave them out, so them too. My educational background includes schooling on the res, high school in the neighboring town of Cutknife, later on to Edmonton for a degree in biological sciences, and then medical school and residency here in Saskatchewan. I'm a licensed family physician practicing and providing clinical, educational, and leadership services to the Battlefords and area. In May of last year, I was appointed as the interim vice dean of Indigenous Health for the College of Medicine. And it's because of this role that I have the pleasure of speaking with you today. So again, sharing this with you to understand the lens in which I see the world. And I'm not positioning myself as an expert in this field, but sharing with you my experiences and lived experiences and hoping to stimulate conversation. So let's jump straight in. Today's talk is about Indigenous health, utilizing a comprehensive definition of health noted here. The World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And so today I'd really like to keep things on the strength-based side of things. We will discuss specifics with regards to the challenges, but again, focus on that, those opportunities, right, when we're considering Indigenous health and keeping it on a strength-based lens. So this picture is of my father and my niece, whose identity we've protected because at the time she couldn't give informed consent for release of her image. And shout out to my sister-in-law who's signing in today, who's responsible for this beautiful Indigenous creature. A bit of a TikTok throwback for you guys. In this picture, my dad there holding my niece, he's 89 this May. And this picture was taken on a day of welcoming and celebration for my niece. It wasn't her birthday. It was a day of love, laughter, family, food, fun, and connection, all for her. We often talk about ACEs, or adverse childhood experiences, that impact children as they develop, specifically Indigenous kiddos, but it applies to all children. But today's topic is Indigenous health. But what we rarely hear of is BCEs, or benevolent childhood experiences, that we know to be protective against mental health issues in adult life. And fortunately, my brother and sister-in-law understand this and ensure that there's tons of BCEs in my niece's lives. And so we are all aware of the deficit-based approach to Indigenous health in our society. And today, I hope that our discussion the theme is optimism and ideas on how community in partnership with health care providers and the health system can drive the change necessary to positively impact Indigenous health. So most of us are aware we have significant diversity in Indigenous cultures, people of Canada. But one central tenet relating to our health for many is the earth-centered worldview and a connection and relationship to the land. For those of you who wish to gain further insight regarding the earth-centered worldview and how it relates to health, you can read Braiding Sweetgrass, which is one such reference that details it quite nicely. There are others, I just have not listed them here. And it's Robin Kimmerer. So next, we'll just move on to the determinants of health. Many of us have seen such a depiction of determinants of health, and we know that health in the global concept of health is much beyond clinical care and medical services. And so I will get you to take a look at the green pie-shaped area there, clinical care, 10%. Many of us, not a lot of us, but some of us equate health with good health services. But this is not necessarily the case when we're considering a comprehensive definition of health. Those of us in healthcare must remember we are a small part of this puzzle. With the known health impacts related to racism in healthcare, however, could this indicator take on a slightly increased level of contribution for Indigenous people and potentially in a negative direction? So that's just food for thought. I mean, I don't have any evidence. I'm not backing this up, just to drive our conversation. And then we look over at the social and economic factors, right? Those 40%. And grouping the social and economic together makes us think that solutions for a healthy society exist beyond medicine and health services. And that's where this community piece comes in, because we can get pretty myopic in our work and in our daily lives, and laser in too narrowly on what health is for a population. And so we're really trying to create that larger perspective on health with our healthcare providers and those working in the health system. So now on to TRC and a very brief review. And I always include this because it's always a reminder to me. I always forget how it all began. And so the TRC was a result of the Indian Residential School Settlement Agreement. And this agreement resulted from the largest class action settlement in Canadian history. That was back then, so there may have been a bigger one more recently. But this agreement was what created the Truth and Reconciliation Commission of Canada, with a mandate to focus on truth determination to begin the work of reconciliation. And to some of us, perhaps a significant event, not on parallel, but nearing signing of treaties. It's really shifted a lot of Canadian thoughts around Indigenous peoples. In all of this, we need to be deliberate about understanding that our Métis and mixed blood relatives, that their experiences haven't been recognized with the same intensity and often responded to in a muted to non-existent way. Many of our non-status relatives face ongoing discrimination through policy and lack of recognition of rights in many cases. The way forward is of inclusion, understanding, and reconciliation for all Indigenous people. And when I use the term Indigenous, I use it in the inclusive way that status, non-status, on-reserve, off-reserve, Métis, Inuit, those First Peoples of our country. And so when we're making the ties to health system, the social determinants of health, racist policies and health outcomes. A very easy example of impact with regards to residential schools on Indigenous health comes from TB data. And you can see depicted here the death rate and of the general population versus the residential school rates, and very stark difference in that. And a tragic example of the impact on health for survivors and their descendants of residential school can be found in the confirmation of the stories that many of us heard of the kiddos that didn't make it home, and the heartbreak of those who weren't allowed the closure. So today, it impacts us all. It still is very impactful with regards to health and achieving health. And so a lot of work obviously needs to be done. We jump forward, and the impacts on health are evident and everywhere. So why is Indigenous health such a hot topic? And why is making advancements and keeping it strength-based a challenge? You know, our history hasn't always been supportive of a strength-based approach to Indigenous health, and Indigenous people recognize that to be allowed to have a strength-based approach, to honor their traditional healing practices and respectfully heal going forward, things need to change. And so the call to action that I highlight here is 22, to highlight the responsibility of leaders and educators in the health professions and the call for respectful concurrent treatments for Indigenous people. Our health and healing systems are to be respected and facilitated. This does not mean that health professionals have an in-depth knowledge of our traditional healing methods, nor should they practice them. But they should know enough and understand enough and respect these practices to ensure safety and effectiveness in the care of Indigenous people. And so this, again, the traditional healing practices and how we as Indigenous people have maintained health or have pursued healthy lives, just being able to pursue that in an environment that doesn't suppress it is a pretty big deal. But having said that, remember, this piece is also like the other contributors to health, a small part. Oh, now it doesn't want to go. Okay. This slide is a quick reminder that the health system isn't working well for a lot of people in Canada. This data reflects the quality of care in Canada compared to 10 other developed countries. Many of you will remember this from 10 years back. So if we look, and I don't usually, I haven't accessed the pointer. Anyhow, if you look at underneath the Canadian flag, Canada ranked the lowest of 11 countries in the timeliness of care. We all have experienced those challenges. And 10th out of 11 countries in safety, which is surprising back then. Unfortunately, things aren't moving all that as much as we would like. Only Norway and the US had more 11s than we did. Not anything to smile about. I share this to remind us that there are many issues specifically impacting Indigenous people in our country, and this is an addition and superimposed to the challenges faced by Indigenous Canadians and all Canadians. Something has to give, something has to change. And so how do health professionals, health education leaders, contribute meaningfully to this change. And so I just want to take a little time to share with you what's happening at USask and get some feedback on how you think this could benefit, or if you feel like it's a total miss. So at USask, many initiatives are underway in many colleges across the campus. And this specific initiative is in the College of Medicine. 20 plus years in the making. The Indigenous Health Committee took this on, and many of which are on the call. And I saw Dr. Leese there. Individuals, Indigenous and non-Indigenous, faculty, staff, students, doing this work over the years to create the change that was necessary. And I, as the interim vice dean, had the privilege of taking that baton through the university governance process and pursuing the new department. The Department of Indigenous Health and Wellness will be the first of its kind in Canada, and is a tangible step towards transformative decolonization, leading to reconciliation for the College of Medicine. And just a little note about the name. It isn't a Indigenous in an Indigenous language. And we did this for clarity, so people understood the functionality of this structure. We also added the word wellness to ensure that this was strength-based. Many communities are moving away from the use of the word health and replacing it with wellness, and some are just adding wellness to health to ensure that we highlight that strength-based approach. And again, Indigenous, the word Indigenous was meant to be as inclusive as intended by the word. So this is where I get even more animated and passionate, and so it'll sound like I'm gonna pass out, but I'm just excited. The academic rationale for this department is to meaningfully address existing health inequities. See, like I just start to, the scarcity of strength-based Indigenous health research, knowledge translation and community. And for those of you who aren't familiar with the terminology knowledge translation, it's just creating research that is meaningful to community, but that translates to benefits or outcomes for community members, and systemic racism in the health system and health education system. So even better yet, this is the powered by community partnership part that sets this department and its structure apart from other similar departments in the college. That was a lot of parts in one sentence. Ensuring community voices are a part of the solutions through driving the questions tackled by researchers and partnering in the change that we need to create. Respectful engagement, honoring the expertise and lived experiences of non-medical Indigenous community members is pivotal to the success of this work. Modeling engagement strategies for respectful community engagement throughout the College of Medicine is an area we hope to support. Community in partnership with faculty, staff, students, and researchers to help determine what those gaps are in building curricular content, building experiences, and a list of skills to better prepare the health providers and researchers to meet the needs of Saskatchewan Indigenous people. Oh, right. Okay. So again, it's also it's a sense, it's a place of ethical relational space that offers safety, where both Indigenous and non-Indigenous who come from differing worldviews can have those conversations and build on the knowledge going forward. It's also a physical space where students, staff, faculty can gather, network, and support one another in the College of Medicine environment. The department will be interdisciplinary and not restricted to College of Medicine or physicians. And then this is just a quick view of our process of development. just demonstrating all the many pieces that are required and the considerations that were made to ensure that this department would be a success. And here's a quick rundown of where we are so far. And we're actually headed off to University Council today for a call for a vote. So send us good energy. And hopefully by this Saturday, when we present to Senate, we have good news to share with all. So I'm happy to entertain any questions, but really interested in your insights or comments regarding what you've heard today, and really looking forward to the dialogue.
Thank you so much for sharing, Janet. While you were speaking, I was just kind of reminded of how close to home so many of these health equity issues hit a lot of us who have, experienced marginalization and who have family and friends who are affected by, historical injustices and all of that stuff. And so I think that the passion is evident and shared by a lot of people who are in the room with us today. So I'm hoping that there might be some questions. Does anyone have any questions? I saw Manuela there.
Can I just thank Dr. Tootoosis for an amazing, generous presentation. And as a DSA, we consider ourselves as an ally unit, which hopefully can help with the institutional accountability and system transformations part. But yeah, we just came back from ICAM. There's a big conversation going around on One Health and planetary health, which is for us is a new concern about whether there's always this newism about creating frameworks that end up not including or actively excluding Indigenous people again. So I don't know if you have any thoughts or comments about that, but I just basically wanted to thank you so much for an incredible presentation today. And I will leave room for the audience's questions.
Also, before I let Janet answer the question, I invite everyone to turn their cameras on so Janet can see all of your beautiful faces and know that she's in a room with 78 people who really enjoyed that presentation.
And it doesn't really have to be questions. It can be comments, or this is an opportunity to share the work that you're doing that ties into this and would benefit the group. So don't be shy. We're among friends here. It's a safe space to discuss.
There's a question in the chat, so I will go ahead and read it. The first one's from Jess Fisher, who works at Out Saskatoon as the gender-based violence coordinator. And Jess is asking, how can we ensure that Two-Spirit people are included in wellness approaches and discussions? Many Two-Spirit people still experience discrimination from their communities due to impacts of colonization, like homophobia and transphobia. So how can we make sure that there's room in the circle for them? And for anyone who isn't aware, Two-Spirit is an umbrella term that encompasses the gender and sexually diverse community who are also Indigenous.
So ensuring inclusion can get very matrixy and complex. And what we have done with our community engagement piece is really, I mean, just to be quite honest, it hasn't been as broad as it could be. When you're considering inclusion, sexuality, those, it's a little challenging because for some it's not a factor. Indigenous is Indigenous, and there's no practice of exclusion. but that's not necessarily active inclusion. And so there's acknowledgement of that. And I think as we engage with community members and those that identify that they want to be a part of it and contribute in a specific way will be welcomed. And that is a principle of the department and office structure with regards to inclusivity. I don't know if that answers your question, but.
I just also know that Jess is so willing and excited to be involved and to help out too. So I'm sure that she'll be a fantastic resource moving forward.
Bring it on, bring it on. Yes, it really is an open door. It's a complex issue. It's tons of heavy lifting. The more, everyone's welcome. We need all the hands on deck and all the help we can get.
And I see that Denise has her hand up. Go ahead, Denise.
Hi, Janet. Thank you for the fantastic talk. I am a public health preventive medicine specialist and currently physically located in Ottawa on the unceded territory of the Anishinaabe and Algonquin peoples. I have I guess, an observation question. I am knowing that University of Saskatchewan is very small and capacity is really challenged, and that oftentimes the same people get finger pointed, the doers get more to do. Has there been any thought about what the impact of the new department is going to be and how well it's going to work? And has there been any review of how interdisciplinary departments have functioned in the university and how that has unfolded? And it, it's food for thought. I don't necessarily expect an answer to that, but I think that I'm just a bit concerned about the heavy lifting that is required. And then the other observation, I'm doing some work for the public health preventive medicine training program on the new standards, accreditation standards. And so I have been doing some background reading, and there is a series of papers for addressing the CanMeds 2025. So the competency framework for physicians is under review. And two of the areas that are being looked at for incorporation into the competencies relate to anti-racism and equity, diversity, and inclusion. And one of the comments from the paper, which really kind of, I guess, took me by surprise because I've never seen it so clearly in black and white, says all physicians in Canada, whether they are engaged in medical education, training, scholarship, or practice, must recognize and accept an uncomfortable truth. The foundation of Western medicine is grounded in racist practices and ideologies which persist today and affect patient care and interactions with racialized colleagues. And I don't think that there is, like, if I'm kind of taken aback by seeing that in black and white, and I, in some ways I consider myself an informed person in many ways, it was like, oh my God, that's so true, but I hadn't thought about it before. So again, just food for thought about some of the other awareness that needs to go on to make this a success in the College of Medicine. Thanks.
Brilliant. Thank you very much, Denise. And the challenge of capacity is a consideration at all levels of the development of such a department, and a consideration everywhere. We want to create this safe space. We want to be able to recruit and attract talent, but we don't want to deplete other communities, other areas. And yes, Indigenous faculty, leaders, physicians are a scarce resource. However, I failed to mention in my brief description of the department that it's Indigenous led, not Indigenous only. And the acknowledgement and recognition of the great work that's going on presently by individuals such as yourself, investigating these areas and learning learning about what the best way forward might look like. And so creating this space, Indigenous-led, utilizing non-traditional structure to facilitate interdisciplinary collaboration. Also, because it's within the College of Medicine, we can access associate faculty, clinical faculty that aren't otherwise engaged. And so some of that tension from stealing from other departments, if you will, is lessened, because clinicians can be in their department and still work in this department, say 0.2 FTE, right, and contribute to an academic piece or an administrative piece of some sort. So we're very cognizant of the limited resources and actively strategizing on how we don't overburden the few individuals we have working in the area, both Indigenous and non-Indigenous. And if you are addressing CanMed's 2025, I applaud you and celebrate and say, yes, yes, yes. There are no anti-racism standards noted in accreditation. And we all know our medical institutions, they move when accreditation speaks. And I think it's a deficit. I think it's well known to Indigenous populations, the impact that racist policies and systemic racism in the health system, we feel the impacts, we live the impacts. So it is not surprising to us that it's not palatable, and it's a challenging way forward, but we know EDI is an excellent mechanism to mitigate racism in systems that are baked in, right? So it's EDI may be a little more palatable as a mitigation strategy for some of those baked in racial policies, or racist policies rather, in the health system. So thank you very much for.
Got another question in the chat. This one is from Jocelyn. Jocelyn is in student health at the U of S. She said, where can we find resources on traditional Indigenous healing methods? Again, not to practice, but just to be aware of. We can research this ourselves, but is there anyone who could share these teachings in person with health professionals wanting to respect those who hold this knowledge?
So really, we have to understand in what context we're wanting this information. So myself as a provider in health, I need to understand specific practices and how I might tailor my Western trained therapies to augment what they're currently doing. And so understanding traditional therapies, it's really about the context. If you're treating someone and they tell you, I'm receiving traditional healing through so-and-so, your best course of action is to ensure that you have good rapport with this individual, and you are very clear on your reasoning for your questioning, right? And so if you're wanting to understand more about the therapies that they're receiving, to ensure that your therapies align, not to discredit or not to say, no, you can't do that, but to understand how we best optimize this individual's treatment plan, then your best bet to understand traditional healing practices is engage with those you're looking after and ask them what they're doing, who they're seeing, what specifically do they know about the treatments they're receiving, and whether they feel that what you're providing is complementary. But to just study it without the practical side, by some people is deemed a little disrespectful sometimes. Like if I wanted to study a religion and just cut it up, not being from there, not having any practical application to that knowledge, then it becomes problematic. But otherwise, talk to the people you're looking after, talk to the people you're working with, natural curiosity, respectful curiosity, because there's varied ways out there, and it's going to differ depending on where you are and who you're looking after.
Thanks for that. Does anybody have any other questions that they would like to ask? I'll ask a question of personal curiosity. So Janet, I think it's really evident in the work that you have been doing and just in your passion that advocacy is a big part of the role that you kind of play. And knowing that we are talking to people who also have the opportunity to be advocates in their community, what do you think is something that you would say kind of like influenced your advocacy journey early on or helped it to grow?
Well, I wouldn't say I started out as an advocate. It was many years of experience in the system, personal lived experience, as well as professional experience that all roads led to advocacy, because when you observe and sometimes are a part of ineffective policy, ineffective strategy decision-making, it starts to weigh on you. And then you realize that you have a responsibility, and we all can carry a part of that. We don't have to come from health. We can all come from our lived experience from our area and offer that opportunity, optimism with Indigenous people understanding that there are elements of their health that they can have control over. And it's not all doom and gloom, and we are a resilient people. And if we are allowed to focus on that, and we're allowed to explore our teachings, our connections and cultural practices, that, yeah, we draw strength from that. So advocating for better can take on a varied array of actions, activities, and I don't think there's any right way to do it. Staying strength-based and staying positive and giving people I think just advocating for that respect and that removal of a lot of those oppressing, often unintentionally oppressing policies and practices.
That's brilliant. I also like that you've emphasized that like an advocacy journey can start anywhere for someone, and like that if you haven't done it in the past, that today's the best day, and it's not about perfection, but just the pursuit of a better future for all of us. So that's really fantastic. Isaac, I see you've got your hand up there. Go ahead. Oh. Isaac, you're muted. Still muted. If you just want to type your question in the chat, I can ask it for you. Gatahan, go ahead.
Thank you. Thank you, Janet, for the nice presentation. My name is Getahan. I'm from the USaskil Sciences. currently located in Regina, and I'm involved with the interprofessional education program at the USask Health Sciences. I have to admit, I'm ignorant on the overall area of the topic, but I was most interested, Janet, if you can trying to understand the way this new department is structured. So is it definitely it is housed within the College of Medicine? So is it like a standalone program, and who is it accessible to? Who are the target learners? Is the curriculum integrated with other programs? Does it lead to certificate or a diploma? I was just trying to understand the structure of the program. Thank you.
Yes, absolutely. Excellent questions. And so right now we're in the process of receiving approval for a department. Once the department is in place, populating the department with faculty will be job number one. Before we can contribute to curriculum, content, teaching, academic programming, we require a base level of faculty, as you're fully aware. And so because this department is just starting from scratch, right, it will be relatively small initially, and ensuring that the capacity is there, that the faculty are supported in the work that they undertake will be, take a lot of the airtime. But programming that is in development is in the master's level training, master's level health sciences. There are some connections with the community health and epidemiology, and looking at how we can integrate into versus create standalone programming within the department. Ultimately, though, standalone programs may evolve as deemed, efficient, but no, not efficient, viable, but also effective, right? We have to understand the goal of such programs before we undertake a program just to have a program. We're not going to, we have to meet certain criteria from the university governance structure, and we do have academic programming planning in place that will meet that criteria, which will support health science students, medical physicians, family physicians, undergraduates, and other postgraduates. So fellowship opportunities, master's level courses, and undergraduate level certificates. But really, it's going to be complementary versus, I don't think the approach is standalone at this point.
Thank you very much, Janet.
Any other questions? Well, if you have any questions for Janet that you didn't get a chance to pose, you can certainly get in touch with me, and I can put you in touch with her, and I'm sure she'd be happy to answer them. I just want to extend my gratitude to Dr. Tootoosis for being with us today and sharing all of her wisdom and expertise. If you've enjoyed today's webinar, make sure that you stay connected to the Division of Social Accountability. We love to have a big community of people engaging in this work with us. For our book club this month, we are switching things up and listening to a podcast, and the podcast is on planetary health. It's a conversation with Dr. Courtney Howard. So it's only 1 hour, really easy to join book club this month, and we'll be meeting on April 26th and 28th. There is a link that Carlin shared there in the chat that will connect you to our book club sign up. So we'd love to have you join for that. We're still in the process of finalizing next month's webinar, so make sure that you're signed up for our monthly newsletter, which you can also find at that link in the chat. And the last thing that I wanted to mention is that the Division of Social Accountability is currently in the process of doing a project that's called Anti-Racist Transformation in Medical Education. So if you are a member of the college and passionate about anti-racism and anti-racist practice, then we would also really love to have your support on that particular project. So Carlin will post a link for that in the chat as well. We're having a town hall on April 27th. That'll be our final town hall for people to come and ask questions about the process and find out a little bit more about how they can get involved. Following the webinar today, you will receive a link with a survey. So make sure that you fill that out. If you want to provide any feedback or applause for Dr. Tootoosis, you can do that as well. We will also send a follow-up. In the follow-up email, we'll also include a link to the recording of today's presentation if you wanted to share that with colleagues or friends or whatever it may be. And Janet, I see that there are lots of thanks and congratulations in the chat, so make sure that you scroll through those. And I think that we'll let everybody go a little bit early today. Thanks for joining, everyone.
Hi, my beauties. Hi, love you. Oh, best energy ever. Everything's going to be perfect today. Love you. Thanks, Andrea.